Good day, and welcome to the United States of Care Congressional COVID-19 briefing. During the presentation, all lines will be in a listen-only mode. A question-and-answer session will follow the presentation, and instructions for asking questions will be given at that time. Thank you all for your attention. I would now like to turn the conference over to Mr. Andrew Schwab. Please go ahead.
Thank you. Hello, everyone. And on behalf of United States of Care, welcome to our Tele-Briefing with Andy Slavitt and Dr. Lanny Chen. My name is Andrew Schwab, and I'm Director of Policy, Federal Affairs, and Partnerships at US of Care. Thank you for joining with us in what we hope will become a series of briefings where we bring a critical mass of the tremendous experts and health policy thinkers in the public and private sectors to your virtual ears. I'd also like to acknowledge that we have several US of Care team members on the call, including our Executive Director, Emily Barson, and other members of our leadership team. Over the past 48 hours, in order to support our nation's local, state, and federal officials, US of Care has temporarily pivoted from focusing on policy solutions in the states and to bridge a bipartisan conversation at the federal level to a full court press, bringing our value add to folks like yourselves as you work this historic and unprecedented pandemic. Our focus remains on our mission to ensure that every single American has access to quality, affordable health care regardless of health status, social need, or income, and to be a clearinghouse for decision makers. Our format today is straightforward. Andy and Lanny will open with 5 to 7 minutes of what they are hearing from their significant networks and what they think Congress needs to do and think about. We'll then have an open question and answer session moderated by the call's operator. We have reserved an hour for this call, so please do not be shy, and many of you will not be during the question time. With that, I'd like to introduce our guests. First, Andy Slavitt, who served as the acting administrator of CMS under President Obama and is the board chair and founder of United States of Care. We're also very fortunate to have with us Dr. Lanny Chen, the Director of Domestic Policy Studies at Stanford University's Hoover Institution, advisor to 4 Republican presidential campaigns, chairman of the board at El Camino Hospital in Northern California, and also, we're very proud to say, a United States of Care Founders Council member. And with that, I'll kick it over to Andy to start us off.
Thanks, Andrew. And good day, everybody. I hope everybody is feeling well and comfortable and safe, and that your families are well, and recognizing that everyone's going through a kind of massive adjustment to what is really a very different footing for the country, and the very important role that you all have to play along with the members who you work with every day to help us out of this solution. We are going to be, for sure, in this for a long while, and it is going to be unprecedented, and it is critical that we work together. And so I'm thankful of Lonnie and everybody else, but I would tell you that there's not a person that I've talked to that isn't willing to roll up their sleeves, volunteer, do what they can to help, provide honest guidelines, and try to solve problems. There are too many problems right now to solve. I myself have spent the last 72 hours working with the White House team that's focused on this issue, working on a public campaign around social distancing that's called #StayHome. Been working on, we just sent a letter to every major state and city official in the country around recommendations and advising them. And so I'm going to talk about some of the macro picture issues very, very quickly. I'm probably going to say things that most of you already know, but I think it'll be good to get some of these things clear and out there. And then Lonnie, just as a compliment to that, because he is also the board chair of a hospital in one of our hotspots, is going to provide you a picture of what things look like on the ground. And I think the one thing you will probably come away with is anybody who has talked to people in Italy or in Seattle or in China has a very, very different view of this crisis. And in fact, you start to see some things that are concerning, but things we should come to grips with, such as when the healthcare workforce begins to wane, as it has in Italy and it did in China, the death rate starts to shoot up. And so we are really, I think, desperately focused on a few different areas that I think are of just fundamental importance. And I'm going to just give you the buckets of those. And we're going to obviously leave time for questions. But the first is our healthcare workforce and protecting them. They are on the front lines of this battle and are very, very scared. I've talked to nurse leaders who are not being told how much protective equipment they have, personal protective equipment like masks. I then pick up the phone and call the CEOs who tell me that who told me that they can't say anything because they don't have much more supply left. These are in areas that are not yet hit by the virus in any meaningful way, but in anticipation. So protecting these workers largely by getting them protective gear, but also by doing any one of a number of things that Congress can do to support them is vital. I think I've uncovered a few things in the last few days that are interesting, one of which is that there is likely to be a substantial amount of hoarding of this equipment going on in the supply chain. The people who produce this equipment don't know where it is. There are also dormant factories in this country that need to be restood up. Those will take a while, but as I said, we're going to need ongoing production, not just current production. The estimates are that we're going to need about 1 billion or more than 1 billion masks produced, and we are nowhere near that capacity. And as we run low, we should be very worried about the healthcare workforce. There are other constraints in the hospital in the system, and I would say just as an outset, these are nobody's fault. We did not build a church for Easter Sunday, and we may look and decide later that we should create stockpiles of many of the things that we don't have that we should have had, but we are where we are because we have we may be shy of ventilators. We're shy of ICU beds by what could be as a factor of as many as 8 to 1, and those are not even well distributed. So as Lonnie will describe, you can hit capacity very, very quickly. Governor Cuomo has done a great job sounding the alarm and being very frank, and the picture he has seen there is essentially what happens if you follow the graph of the U.S., which is about 10 to 14 days behind northern Italy, what will happen. So the second point I've made, so the first point is all around the healthcare system. The second point is because we know the healthcare system can't handle the crush, we have to focus on what people have been calling social isolation or flattening the curve. But we have to take what is today the average person who gets infected infects 2.3 people. The reason a lot of that happens is because people are asymptomatic and because this is highly contagious, as everybody knows, and because we have no immune system. Not even the healthiest among us have an immune system for this virus. It's a novel virus. That 2.3 has to be dramatically reduced. It has to be dramatically reduced if we have any hope of not crushing the hospital systems and the healthcare systems in our country. So by reducing that means we have to get people into social isolation as quickly as possible. How we do that, I think, is not so straightforward, and it's not so straightforward for several reasons. But one of them is that this is going to hit each city at different times. So asking people in cities where and our problem, I think, is going to be largely with millennials and with children. 90% of children will be asymptomatic. Millennials have a hard time believing something they can't see like this is going to impact them. And so we launched a major campaign that from 16 healthcare leaders that are from both parties and in public health called #StayHome. It's the website, Stay Home, Save Lives. And we have entertainers, media people, sports figures, and others who are going to be promoting this. We have the top 100 YouTubers on this, but this should be in the messaging of, I think, of every one of our members as they're talking to folks. And it can't be just about what you can't do. It has to also be about what we can do. We're going to have a new normal for at least a period of time, and we're going to have to build a little bit of a culture around people staying at home and making it enjoyable and looking at the positives and so forth, because people, are going to have to do this. I think most people I've talked to would tell you that we probably have, for people who aren't panicked, it's probably okay to panic them. Now, living in a state of panic does nobody any good, but if you haven't gotten there and gotten people to that realization yet, we don't have a chance of reducing the contact points in time for the herd immunity to build up or for us to have a vaccine. So that's the people at the state and local level. Healthcare officials at the state and local level are doing their best. They are working as hard as they can, and we are doing whatever we can to support them. They are desperate for federal leadership. They're desperate for help with these problems we've talked about. They're desperate for help from Congress. Thank you all for supporting, moving forward, the packages you have so far. I suspect it will be an ongoing job. I don't think it will be done. My, I guess, unsolicited advice is the way to get people to stay home is the people who live paycheck to paycheck need to feel like they're taken care of, or they're not going to stay home. And so this idea of direct payments, I think, is very, very important. I would say go big. As big as you think it should be, it should probably be bigger. And part of that should be, in my view, and Lonnie and I talked about this, probably something special for the healthcare workforce. We, in many ways, need to think about them like our military. I'll make a final point, and then I'll turn it over to Lonnie, which is that where we're going to see, if we see a high death toll versus if we don't see a high death toll, it's going to do with how well we protect the vulnerable population in this country. Think about the fact that if a very bad flu went through nursing homes, it would wipe out large portions of the population. Now, to be blunt, nursing homes are not very good at infection control to begin with. 30,000 people die every year of an infection in a nursing home that's unwarranted. So in a situation like this, it's going to be even worse off. Now, nursing homes are supposed to do infection control. What about elder care communities, senior living, any other place where seniors congregate? We will have potentially very, very high death tolls if we are not highly protective of those communities. But other places where people live in close quarters, whether it's in cities and low-income communities, whether it's in prisons, those are all places that we should be very, very focused on and careful about in protecting that population. Finally, while I think there's this meme that is mostly true, that this is about old people are most at risk, there is, we are still early days. There's not a lot of facts yet. We don't know everything for sure, but one thing that we do know is that people who are, no matter of any age, that have an underlying condition are at deep, deep risk as well. We don't know the numbers, we don't know the likelihood, we don't know the percentages, but they are potentially deeply at risk as well. And so there are vulnerable populations and all sorts. I'm going to stop there, and I'm going to hand it to Lonnie. And Lonnie, who's got a lot of expertise and a lot of experience, feel free to disagree or agree with whatever points you think you need to, since there's no monopoly on what's going on here.
Andy, thanks, and thanks for how you've led on this initiative to promote social distancing. I think it's hugely important, as we all know. What I thought I would do, since you've probably got plenty of people talking to you about the macro level, and I think Andy did a nice job of outlining some of the issues at play there, is I want to talk about what's happening in one of the country's hot zones where I live, here in Santa Clara County, California. In fact, the first COVID-19 hospitalization happened at El Camino Hospital, which is the hospital group that I'm the chair of the board of. And so we've actually had quite a bit of experience with COVID-19 and dealing with the proper protocols and procedures for addressing how we treat patients, how you treat patients who aren't coming in with respiratory symptoms, and the best practices to ensure that we're not facilitating community transmission of what has been a very difficult virus to handle. I'll just say that overall the coordination in Santa Clara County between all of the different healthcare providers has been very, very good. That interaction is being facilitated by the healthcare providers, not necessarily by the county public health authority. And I'll just say I know that they're very busy. They have a lot going on. In fact, they are busy today trying to figure out the best way to enforce the shelter-in-place order that we're all under now as of midnight last night here in the Bay Area. From my talking to people who have been out today to pick up essential items, et cetera, the people of this county are doing a good job of observing that shelter-in-place order. So hopefully that will begin to show some impact here in the coming weeks. The local healthcare providers here, the CEOs of all the major hospitals, we have one major teaching hospital in the area here, that's Stanford University Medical Center, as well as the community hospitals, of which there are several excellent facilities, have decided to convene every day a call to talk about scenario planning and to discuss what's going on. So just to give you a sense, we at El Camino Hospital, which is about a 400-bed hospital in Mountain View, and an 80-bed hospital in a city called Los Gatos, which is down the street, which is where Netflix is headquartered. We have 80 beds down there. We're averaging anywhere between 2 and 4 coronavirus cases in-house, and the average hospitalization time for those cases is 3 weeks. Unfortunately, we did have the first patient to expire because of COVID-19 was a patient in our hospital, and it was a woman in her 60s who had severe underlying respiratory conditions. In the county overall, I know that there's a couple issues that have been discussed. I want to talk about bed capacity, about supplies, and finally about testing. This county is actually relatively well off in terms of the number of ICU beds that are available. So in the county, our capacity is about 285 ICU beds. Currently, we have about 90 beds occupied. We anticipate that that number will roughly double every 5 to 6 days without any mitigating orders. So this obviously does not assume shelter in place. We're hopeful that the kind of social distancing that the county has enforced and will enforce will ensure we don't get there. But you can quickly do the math, which is within 3 to 4 weeks, the number of ICU beds will be swamped by the number of people who will need them. And so, we really see here the next 3 to 4 weeks as critical in terms of determining our ability to push back on this virus. We are seeing, for the most part, I know that most people are observing, or most authorities observe a 14-day incubation period, but the vast majority of patients are presenting with symptoms 5 to 7 days from exposure. The equipment issue continues to be a challenge. I will say that in this county, it's not so much ventilators. The county public health authority has about 700 ventilators stockpiled, which should be more than enough, as I noted earlier, given the ICU demand. What we are finding is a shortage of 3 things. One are things called PAPR shields, which you may be familiar with. Those are the larger protective devices that go over an individual who's already wearing a proper mask to further protect the healthcare worker from exposure. PAPR shields are in remarkably short supply, and most hospitals are laundering PAPR shields, which is not what the manufacturer recommends. The manufacturer recommends use and disposal, not reuse, and that's something that we're having to deal with. The second item, believe it or not, we're having a tough time with are infrared thermometers. These are really important for detecting at the entry point to the healthcare facility those who are potential COVID-19 patients, and then engaging in the proper triage to ensure that those patients do not expose other patients seeking care either in the emergency room setting or in an ambulatory setting outside of the hospital. So infrared thermometers are in demand. And the final item, which will come as no surprise, are the N95 masks. Some call them respirators. The idea is that every time after you use a mask, you're disposing of it. So the burn in a hospital like ours is about 300 masks per day. And so we've recently, at our hospital, just gotten an order for 80,000 of these delivered. But other hospitals in the county are struggling to get their hands on the N95 masks they need. So that will continue to be an issue. So the big supplies, as far as we're concerned, as I said, the PAPR shields, the masks, and then the thermometers. The last point I'll just make on the micro, and then I'll just say a few things about the macro to echo what Andy said, is testing. So it is the case that testing capacity has increased significantly, particularly in the San Francisco Bay Area generally. But I think what we're finding is that the turnaround on test results is still unacceptably slow. And so we're still seeing 24 to 48-hour turnaround periods on test results. At our hospital in particular, it has to deal with the fact that we can't run tests on site because the reagent that we would use for the machine we have is not FDA approved. There are a few reagent manufacturers, as I understand it, that are still seeking FDA approval. This would be one area where we certainly could use some help on the regulatory side, which is trying to expedite FDA approval of additional reagents that are in the pipeline for use, particularly on site at healthcare facilities. That would help us tremendously to be able to diagnose COVID-19 more quickly and put in place any necessary curative therapeutic interventions as soon as possible. There's been quite a bit of evidence so far that some of the experimental therapeutics, if administered early on in the course of the virus, can be highly, highly effective at turning the tide. So the challenge is if we're not getting people diagnosed for 48 hours, it's 48 hours we're losing while determining whether to administer the particular therapeutic. So that's just sort of a view from the ground here. I provide that just because I know sometimes when you're dealing in federal policy in particular, it can be hard to see what the view is from the ground. We have 155 confirmed COVID-19 cases in Santa Clara County as of about 30 minutes ago, and of course anticipate that number to rise. We're continuing to see a decent number added each day, and we do have quite active community transmission here. In terms of the macro issues that Andy raised, I would completely agree that some sort of direct assistance is warranted, some sort of direct assistance that is relatively robust, and in particular the healthcare workers are working a tremendous number of hours and really doing incredible work to keep people as well as they can, and should be considered in any aid package. Obviously my preference would be to ensure that the assistance is more limited in scope, but clearly a lot of people believe now that a broader based approach is the right one, which I fully respect. But I would just say I do think the healthcare workers need to be particularly cared for, because the reason, by the way, that the ICU beds are limited has a lot less to do with physical plant and much more to do with which critical care nurses can actually staff those ICU beds. We would not have a problem at our hospital turning around an additional 40 or 50 ICU beds, but we just don't have the staffing to fulfill that obligation. And so ensuring that our healthcare workforce is cared for, I think, is particularly an important priority. So with that, why don't I turn it back over to Andrew and to the team for questions, and happy to do what I can to answer any questions about what might be happening here or how else we can fight this thing.
Thank you. At this time, we will begin the question and answer session. If you would like to ask a question, please signal by pressing star 1 on your telephone keypad. If you are using a speakerphone, make sure your mute function is turned off. Again, press star 1 to ask a question. We'll pause for just a moment to allow everyone an opportunity to signal. And again, to our audience, to ask a question, you may press star 1 now. And we do have a current question in queue. That question is coming from Katie Meyer with Kevin McCarthy. Please go ahead.
Hi guys, thanks for doing this. I had a question about the healthcare workers, which agree I'm pretty worried about. What kind of assistance are you suggesting, and also are you seeing issues with healthcare workers having trouble getting to work because of child care issues at the schools being closed?
Katie, it's Lonnie Chen. I'll handle that first, and then Andy, if you've got thoughts about the assistance in particular. We have found that it is a little bit of an issue here. So our local school districts are obviously all completely shut down through the middle of April. Now, some localities are offering essentially a form of child care, but the child care hours are limited. And there are very specific rules regarding who does and does not qualify. For example, I think up in San Francisco, that jurisdiction has a more robust child care system, a child care program than we have here in the Santa Clara County area. But I have heard from a few of our healthcare professionals that the child care issue does remain a sticking point. I'm not sure, quite frankly, that there's a great way to address that, given that we are concerned about spread amongst young people, not so much because it'll affect them, but they are clearly asymptomatic carriers of the virus, and they can pass it on to parents and grandparents, and so we don't want them congregating either. So this is a challenge that we are seeing. But yes, absolutely, I think it is a concern, and it is something that we're trying to monitor and keep an eye on as we begin to staff up around some of the surge we're seeing at some of the hospitals in this county.
So this is Andy. This is a really couldn't be more important question and a very challenging one. If we were to just put aside U.S. customs and habits for a second and say, okay, what worked in China? What did it work to start to lower the infection rate, and when did we start to turn this around? They put their medical workforce into dormitories. And protected them from any exposure, and that is something that I think we may look back on and say was a pivotal reason why they were able to eventually get this under some control. We have to think of some creative, out-of-the-box solutions on child care, because these little kids are, they're spreaders. And as Lonnie said, 90% of them are asymptomatic entirely. They get in all kinds of places. So if they are, in a child care facility with kids whose parents are not part of the medical community, and they catch things and bring it home, this is not a good situation. So, one of the questions is, can you have in-home child care for at least your frontline nurses, CCU workforce, doctors, critical people we need? And the answer to that is we have to figure out how to try. And so when Lonnie and I talked earlier about potentially having some sort of additional assistance, if you considered financial assistance for those workers and said, we are going to give you some financial assistance to afford in-home child care, and then you take many of the people that are going to be looking for work every day from Marriott Corporation and all other places, and activate them to say, hey, why will you, and it doesn't have to be necessarily just one child in-home. It could be something a little more efficient. It could be a few kids. You will end up in a much, much better place because we are all going to live with the lowest common denominator of what happens when this disease spreads. So I think that I saw data, I don't know if it's reliable, that said that 10% of the doctors in Italy in those hospitals have contracted COVID-19. A 10% reduction in the workforce, if that's what is ahead of us, even a 10% reduction on Lonnie's hospital and every hospital in your districts around the country would be a really significant blow. So as quickly as we can get those sort of solutions to people, I also think ideas like take the Teach for America Corps or other healthcare workforce corps and say, we need you now to take care of these kids. And I don't mean to just focus on the kids of healthcare workers, but in some senses, think about them as a special class like we think of veterans, and drive policies that really help protect that group would be my suggestion.
Yeah, good. That's helpful. Are you saying actual Teach for America, or are there other health corps workforce? Are there people in particular you think can help with that?
Yeah. I mean, look, we're going to have to be creative here, but there's a lot of teachers, and I think what's interesting about Teach for America is they have nothing to do, and they're young. I have one of the people on my team is a med student, and she organized all of the med students at the University of Minnesota Hospital to do all the child care for all of the frontline workers at the University of Minnesota. And it's brilliant because these are people that get the medical context. They want to help. They're in med school for a reason. So, these things are happening organically, but they're not happening in any way that sort of is a demonstrated best practice. The quickest way for that to happen is for Congress to do something that calls attention to it and then has people locally, take advantage of a bunch of different people who may be designated as capable. So I use Teach for America as just as an example, not as the answer.
Mm-hmm. Thank you.
Thank you. And again, as a reminder to our audience, you may ask a question by pressing *1. We do have an additional coming in. Just one moment as we gather those lines. Our next question is coming from Aisling McDonough. Please go ahead.
Hi, this is Ashley McDonough from Congresswoman Anna Eshoo. So thank you, Lonnie, for speaking about El Camino Hospital because it's in our district. My question for you on the issue with the FDA approval on reagents. Can you speak more specifically about what you're looking for and what you need from Congress to help you fix that problem?
Yeah, it's my understanding is that the reagent is, so there's two, and we can follow up with the exact names of the manufacturers of the two reagents. There have been a number of reagents that I think a Roche reagent was approved this week, which is great, but for some reason there are few that correspond to the particular machine that we have at the hospital that could run these tests that we need, and neither of those reagents has been approved by FDA. So I don't know if it would be an inquiry directly with FDA regarding the status, if there is a regulatory issue that's inhibiting the approval of these reagents. I'm not aware of what the specific issue is. All I know is the reporting from our frontline staff that the presence of these reagents would speed up tremendously the ability to process these tests on site and get answers more quickly. But I can follow up with you with the names of the manufacturers, and then that inquiry probably should happen with FDA directly.
Great. That sounds perfect.
Thank you. We'll go to our next question. That question is coming from Alex Urey of the Office of Speaker Nancy Pelosi. Please go ahead.
Hi guys, thanks so much for speaking to us today. Andy, I kind of had a question just about the ability for our manufacturers to scale up capacity for PPE. I know you said we kind of need 1 billion masks right now. I'm curious if you, or Lenny, if you've had any conversations with manufacturers about how much they think they can scale up in the coming weeks and months.
So I have, and I don't know if Lonnie has, but I'll start. So the good news is we are absolutely sub-optimized. I'll give you an example of a conversation I had with one of the manufacturers. I asked them, are you still fulfilling all of the orders that you fulfilled prior to the outbreak? And they said yes. And I said, how many of those are going to frontline healthcare workers and how many are not? And they said, we don't know. I said, well, you should know. You need to know, and you need to stop those other orders. They've increased capacity in some respects, but they've also told me that they want certain things from like liability waivers and guarantee of labor and guarantee of pricing. One even asked me, would the government guarantee payment for these masks? To be honest with you, I said, you've got to be kidding. I would guarantee you payment for these masks. Obviously, there's going to be demand for these masks. But, we have a little bit of an interesting phenomenon going on where some of the companies aren't, and I don't mean to say this to be dramatic, but they aren't on war footing yet. They know something's happening, obviously. They've gotten calls from the vice president, and they're certainly doing more, but they're not completely getting, they're still a little bit in business as usual mode and, thinking about the issues that they normally think about, liability, pricing, earnings, et cetera. And so we could do more to activate them. Furthermore, I'm convinced that because all of these guys sell through wholesalers, that the wholesalers are a critical key here. As I said, I'm pretty certain that there's hoarding going on in the supply chain, and I'm pretty certain that even if there isn't hoarding going on in the supply chain, they're not distributing the masks to the people in greatest need. What we need is some central policy which distributes the masks to public health departments in the states and have the states distribute them to the hospitals, as opposed to what we have now, which is, everyone wants them. Everyone wants to buy ahead. It's not just the U.S., by the way. The companies are manufacturing them for other countries. That's not necessarily a bad thing. We're connected to the globe, and if it happens over there, it happens everywhere. But there's really no central underlying policy. Now, having said all of that, I think if we did all of those things and brought all that stuff online, we still wouldn't have sufficient N95s for the workforce. We would, if we hit the need that we foresee, we will still have a massive shortage. So we should do all of those things, but that puts more emphasis on the social isolation, hashtag stay home. It also means that we need other creative solutions. People are starting to ask questions. What happens if you microwave them? Does that work? There's been all kinds of opinions that those things don't really work. They're not recommended. But in a situation where it's that or nothing, the question is, can you get some effectiveness out of it? I think we should have a definitive, and we should get the smartest people to tell us what the definitive answers are, and we should do the very, very best we can. Everything we do, not being able to solve this thing entirely shouldn't discourage us, because everything we do, we're going to save people's lives, and that's a good thing.
Yeah, I mean, I would just add the way the supplies are distributed is clearly a little bit of a mystery. And to Andy's point, I think it's entirely possible and highly likely, in fact, that there is some hoarding going on. I will say, for example, what we have done in terms of the supplies that we need, and we've traditionally worked with a GPO. And the GPO fulfills the order. So with something like N95 masks, we were able to get those relatively easily, but we can't get thermometers because for some reason the GPOs or even in some cases if we go to the providers or manufacturers directly, they'll tell us they just don't have stock sufficient to fill those orders. There does not seem to be a lot of rhyme or reason to why an order is fulfilled or unfulfilled. And to that point, it would seem to me that you would want those supplies to be going into areas where they are actively needed as opposed to areas where the need may not be acute. Now, the challenge with that obviously is this thing can shift on a dime, and you want different places to be able to have access to all the PPE they need. But I don't think it's a particularly good thing that in the middle of an outbreak, you're having to beg for what are basic supplies. And so obviously I think we need a little bit more of a concerted policy response around how this PPE is distributed and how it gets to the front line.
Thank you both.
Thank you. And at this time, there are no additional questions in queue. Before we conclude today's conference, do our speakers have any final remarks?
This is Andy. Maybe I'll close the call. Thank you all for the work you're doing, and just to, we're going to need to be very, very nimble, obviously, based upon the fact that if we'd had this briefing yesterday, I think it would have been 30% different than it is today. And if we had it 2 days from now, it would be different again. I think by dedicating United States of Care's workforce and team 100% to supporting you and the states with the coronavirus, we hope to be able to do as decent job as we can fielding questions as you have them, getting them to experts, and getting them and trying to get you answers and support the best we can. Andrew is the point person for you. Our head of policy, Kristen Mukelius, is amazing and coming up to speed fast. So it's not a big team, but we're going to try to be there to help you in any way we can and access people like Lonnie and myself and other people that you need.
Thank you, sir. And thank you all for your attention. This concludes today's conference. All participants may now disconnect. Thank you, sir. And thank you all for your attention. This concludes today's conference. All participants may now disconnect. Thank you, sir. And thank you all for your attention. This concludes today's conference. All participants may now disconnect. Thank you, sir. And thank you all for your attention. This concludes today's conference. All participants may now disconnect. Thank you, sir. And thank you all for your attention. This concludes today's conference. All participants may now disconnect. Thank you, sir. And thank you all for your attention. This concludes today's conference. All participants may now disconnect. Thank you, sir.